Welcome to the Parkinson's Foundation and AARP joint webinar series. Today's topic is Medicare and Parkinson's, what you need to know. Hello, everyone. My name is Adolfo Diaz, your moderator today. I'm the Associate Vice President for Information and Resources at the Parkinson's Foundation. And in that capacity, I have the pleasure of overseeing our 1-800 toll-free helpline. For those of you who are tuning in for the very first time, we're so glad to have you here today. This AARP and Parkinson's Foundation partnership will help reach even more people with Parkinson's and their care partners to provide the tools, information, resources, and the community they need to live better with Parkinson's disease. So before we get started, there's just a few little tips and tricks, webinar tools we want to share with you and make sure everybody is comfortable. First feature we'd like to point out is the question and answer icon that's located at the bottom of your screen. This is where you can type in your questions or message us if you're having any technical difficulties. We'll be answering as many questions as we can towards the end of the program. And if you open your chat box right now, you'll be able to find the link to download the slides. The slides for today's webinar. This webinar is being recorded and it's going to be available on demand within 48 hours. All of those who are registered will be receiving an email link, so you don't have to do anything. It will also be available on the Parkinson's Foundation website at parkinson.org/AARP2021. So before we begin, we'd like to take a moment to get to know our participants just a little bit better. So we're going to ask you to take a moment and answer the questions below that you'll see on your screen in the poll. What best describes your connection to Parkinson's disease? Okay. And let's see. All right, so it seems like about 62% of our audience are individuals with Parkinson's, about 23% care partners, and we have quite a few health professionals and some friends, as well as some other family members. Thank you for doing that. So it seems it's my pleasure to welcome our very first guest speaker, which is Tricia Sandiego. Tricia is a senior advisor for AARP's caregiving and health team. Her current work focuses on strategies for educating those aged 50 plus and their families on caregiving and healthcare through programs, online tools, and resources. Today, Tricia is going to be speaking to us about understanding your Medicare benefits. Welcome, Tricia.
Thank you so much, Adolfo. I'm just going to switch over to my screen and share my slides. I have to thank everyone for being here today with us. It's my pleasure to provide information on Medicare. Medicare can be kind of tricky. It's a bit of an alphabet soup, and understanding the basics is definitely something that can be helpful. Even if you feel like you already have a firm understanding of it, it's always good to have a refresher. So this is going to be sort of Medicare 101. We're going to talk about understanding your benefits as a Medicare beneficiary. The agenda today from my portion is going to talk about those basics, those sort of firm foundational elements of Medicare that it's important to know. Then I'm going to talk about your Medicare choices. What are your pathways to get your Medicare coverage? What are the main options that you have? And then we'll quickly go over some resources and tools. So going back to the basics, as I mentioned, everyone might be at sort of different levels, but as you may or may not know, Medicare can get confusing pretty quickly, pretty easily. And so I think if this is a refresher for some of you, welcome. And for some who are new to this Medicare world, take the time to really understand each of the different parts and components. If you get overwhelmed, don't get frustrated, because know that it is easy to get overwhelmed with this topic. There is a lot of information to digest, and everyone's situation is unique. And so it's kind of hard to tell you sort of a one size fits all rule when there is none. And you really have to look at your own options and decisions that you have, what your lifestyle is like, and see how that fits in with your Medicare options. First and foremost, what is Medicare? Medicare is a federal health insurance program for people who are mainly age 65 and older. Under age 65 with certain disabilities are also eligible, and then also people who have end-stage renal disease are also covered through our Medicare federal program. Let's take a quick quiz. I'm just curious to see, just to kind of get a sense, and no problem if you're purely guessing, but do you think that Medicare enrollment, enrolling into Medicare, is that something for the first time? Is that something that's automatic, or is that something that you actually have to do? Or is it something where it depends? As I mentioned, everyone's situation is unique, and so maybe that's the option. Do you think it's automatic, or do you think that it's great? Okay, so we have 83% of people saying no, it's not automatic, 6% saying yes, and 11% saying depends. The correct answer is actually it depends. So both yes and no are correct, and you'll hear a little bit more about that later, but I'll quickly tell you, it depends mainly on whether or not you're collecting Social Security benefits yet. So let's say you did early Social Security benefits, you collected those early at age 62, and when you turn 65, Medicare enrollment actually does tend to be automatic for you. It's good to always confirm and call, but if you already receive Social Security benefits, it's automatic. If you do not yet have not yet received Social Security benefits and you're approaching age 65, or if you're continuing to work past the age of 65, you do have to manually opt in and enroll in Medicare yourself. So for that, the answer would be no, it's not automatic if that's your situation. So as you can see, it depends. Going on to the next slide. I'm just going to give you some foundational glossary terms, which you may know already through sort of previous health insurance coverage. You really have to kind of get to know these terms, and these same terms apply in the Medicare world. A premium, a monthly premium, is the amount you pay to Medicare or a private insurance plan for your healthcare and your prescription drug coverage. It's something that comes out every month that you have to pay. A deductible is a certain threshold amount. It's an amount that you owe for healthcare services that you have to pay before your health plan or your Medicare begins to pay. And the deductible may not apply to all services. A coinsurance, this is usually a percentage. It's the amount that you may be required to pay as your share of cost for services after you pay your deductible. So this is sometimes a 80%, 20% rule where an insurance coverage or Medicare will pay 80% and you pay 20%. That's the coinsurance. And then co-payment is usually sort of a set fee for certain services. For a covered health service, usually when you receive the service is when you pay, and the amount can vary depending on the type of insurance that you have. What does Medicare not cover? In general, original Medicare, and we'll talk about what original Medicare means. Original Medicare does not cover vision, dental, hearing, things like hearing aids, nor long-term care. And the fact that Medicare does not cover long-term care can actually be surprising to a lot of people. Medicare only covers certain services if they are medically necessary, and it does not cover custodial care, which helps with ADLs, your activities of daily living, such as bathing, eating, dressing, and using the toilet. So just something to clarify, because I know it's a point of confusion. Medicare does not cover long-term care. The other components I have here, vision, dental, hearing, sometimes can be covered through Medicare if you have a Medicare Advantage plan, and we'll talk about that later. But in general, if you have sort of traditional or original Medicare, that does not normally include vision, dental, or hearing. Now, let's go to the different parts of Medicare. I said it's a little bit of an alphabet soup, and you'll see why. It's because there's all these different parts, and the main parts are A, B, C, and D, and I'll go through those. I may skip around a little bit, but it'll just give you some basic information about each of the parts. Part A is hospital insurance. This will cover things like inpatient hospital care, some hospice and home health care, and some skilled nursing care. Part A costs are generally, there's generally no premium for Part A. Most people who qualify don't pay a premium for our Part A because you already paid that through payroll taxes while you were working if you were previously employed. If you do not have premium-free Part A, you may be able to buy it under certain conditions. Part A does have co-insurance in addition to a deductible. We talked about those terms earlier. The deductible for this year in 2021, and it does change year to year, is $1,484 for days 1 through 60, the first 60 days of inpatient care in a hospital. The deductible can be applied again for additional hospitalizations after 60 days. Part B. Part B is your medical coverage. This is going to be things like your doctor visits, laboratory tests, rehabilitation services, x-rays, some mental health services, outpatient hospital services, and durable medical equipment, such as wheelchairs, walkers, hospital beds, for example. And so Part B is going to be, things like your appointments with your doctor. That's separate from Part A, which is your hospital. Part B costs, again, these change year to year, but the general standard monthly premium is $148.50 in 2021. And these are for those enrolling in 2021. Premiums do go up for those with higher incomes. And so if you have income and you're an individual that's more than $88,000 this year, then your premium will go up. Depending on how much you pay, how much you earn. And then couples, those who file married joint in tax returns, those who earn $176,000 or more will also pay a higher premium above the standard premium, which is $148.50. There's also an annual deductible for Part B coverage. In 2021, the cost is $203. And generally, co-insurance, that percentage of cost sharing that you pay, is roughly 20%. I'm skipping Part C, and you'll know why. We'll go to that later. Part D is drug coverage. So I remember D for drug coverage. This is prescription coverage. It helps cover the cost of prescription drugs that you pick up at the pharmacy. And it's run by Medicare-approved insurance companies. You must join a plan in order to get Part D coverage if you have original Medicare. Medicare D is provided by standalone Medicare prescription plans, and sometimes they're also covered through Medicare Advantage plans, which we'll talk about later. But in general, if you go through original Medicare and have Parts A and B, then you do need to select and actively enroll in a Medicare Part D plan. So you have to kind of choose which one works for you, look at the medications that you take, and before you pick a plan, I encourage you to really see if that plan covers the drugs that you're taking. The list of drugs that are covered is called a formulary, and when you're looking through the different plan options for Part D, you'll be able to look at that. Medicare.gov has a wonderful resource called the Plan Finder, and that's where you'll be able to kind of do these kinds of comparisons and find out if the plan that you're looking at can cover the drugs that you take. I just mentioned that because I want to caution, don't just go by monthly premium alone when you're selecting plans like Part D plans. Really look at your own coverage, what your own coverage needs are. Look at your list of drugs that you take and make sure that they're covered. Because otherwise, in the end, if you go through sort of the cheapest Medicare monthly premium Part D coverage and it doesn't cover your prescription drugs that you actually take, then you may be paying more in the end. So things to kind of consider when you're choosing. Part D costs. People enrolled in Part D, they may pay monthly premiums, co-payments, co-insurance, just like with Medicare Part B. The annual deductible can go up to $445. And similar to Part B, people with higher incomes do pay a higher Part D monthly premium. Now we're going to go through Medicare Choices. So I talked about sort of the basics in terms of the Parts A, B, and D. You notice that I did skip C. And that's why when you choose your Medicare coverage for the first time, you kind of have to choose between original Medicare, which is Medicare Parts A, B, and D separately, hospital, medical coverage, and drugs. Or you can go with Medicare Part C, which is its own separate path, and that's called Medicare Advantage. Medicare Advantage plans will also include Medicare Parts A and B coverage, and they usually also cover Part D as well. And sometimes Medicare Advantage plans even cover more things like vision, hearing, dental. And so there are some trade-offs between the two pathways to get your Medicare coverage. I think of it this way. A mentor once taught me, think of an analogy of like going to a restaurant. If you go to a restaurant and let's say it's restaurant week, do you want to order from their usual regular menu and pick and choose from the wide sort of selection, kind of have your A appetizer first and you can choose what it is, have your entree, you choose your dessert, whether or not you're going to have one, you choose your other things, and you're just ordering from your a la carte from your regular menu. That's original Medicare. You're kind of getting these components separately. Let's say it's restaurant week and they have this special set menu where you combine and you can get your appetizer, your entree, dessert all at once under this one menu for one fixed price. And you may be saving more money because of the fact that it's the set menu and it's a special for that week. But and you may get like things that you normally wouldn't get. However, your options are limited. Sometimes there's only 2 choices for your entree, or there's only one dessert available through that set menu. So that's just one analogy that I think of when I think of my 2 options for choosing my Medicare coverage. Do you want to go original Medicare, where you're going to get and Part A, B, and D sort of a la carte, you're picking on your own, or do you want Medicare Part C, which is Medicare Advantage? It includes all those parts and then some in some cases, and it's usually at a lower cost sometimes, and you kind of have this plan, but then there are some trade-offs to consider. So original Medicare, kind of going this a la carte route, it's fee for service. It includes parts A and B. A is for hospital, B is for medical coverage. You can generally go to any provider that accepts original Medicare. So if you have a doctor that you like that you go to and you want to stick with them and they accept original Medicare, you can continue to see that doctor. You also have your choice in choosing your prescription drug plan coverage. So as I mentioned, you go on a place like Medicare.gov Plan Finder and you can choose and select your own drugs. And if you have original Medicare and you want to get this prescription drug coverage, you choose and join this plan. And as I mentioned, people with original Medicare can go to any doctor, hospital, or health provider who accepts Medicare. Generally, about 95% of physicians and healthcare providers do accept original Medicare. In addition to the A, B, and D, original Medicare options, you can also buy what I kind of consider a wraparound coverage called Medigap coverage. It's also called Medicare supplemental coverage. It's a supplemental insurance policy to help pay for the costs of healthcare that original Medicare does not cover. It's sold by private insurance companies. It covers those gaps for original Medicare. There are going to be deductibles, co-insurance, and co-payments. And if you have original Medicare and a Medigap plan, you cannot also have a Medicare Advantage plan. As I mentioned, it's sort of 2 different pathways. If you have Medicare Advantage, you are not able to purchase a Medicare supplemental plan or Medigap plan. And there's up to 10 standardized plans, so you can compare them very easily. So that was one pathway, original Medicare, with a Medigap optional supplemental insurance policy if you want to purchase that in order to sort of help pay for the cost of original Medicare. That's parts A, B, and D. That will cover hospital insurance, medical insurance, and drug coverage. That's original Medicare, and then your Medigap will cover any kind of gaps that you don't get covered through original Medicare. Part C is Medicare Advantage. This is an alternative to original Medicare. And these are plans that are offered by private insurance companies. All plans include parts A and B, and in almost all cases, Part D as well. This may limit your ability to purchase Medigap in the future. So if in the future you decide you don't want to stick to Medicare Advantage and you want to go original Medicare, sometimes having not purchased a Medigap plan the first time you enrolled can impact sort of the cost that you pay or your ability to get a Medigap plan based on things like pre-existing conditions. One trade-off with Medicare Advantage is that you have to live in the plan service area, so it's a little bit more limiting. You may have to use providers only in the plan's network. So you may have an in-network list of providers, and those are the only ones that you can go to that are covered. So if you have a doctor that you like and they're not a participating provider in network for that Medicare Advantage plan that you purchase, you will have to switch your positions and go to different doctors, which some of you that might be fine and others it might not be your preference. You may pay an additional premium on top of the standard monthly premium, and that's because Medicare Advantage offers that convenience of sort of a all-in-one, one-stop shop type of place. It's kind of like an HMO in the sense that everything's sort of in the network, and you can kind of get managed all the care in one place. And so sometimes there's an additional premium for that convenience of everything being at one, and then they usually sometimes have that additional benefits like vision, dental, hearing, and that kind of thing. You do have to usually follow the insurance company rules. They may require you to get a referral before seeing a specialist, whereas with original Medicare, you don't need to do that. So it's very network based with Medicare Advantage, and there are sort of limitations. Things to consider: do you travel a lot domestically? You may not have that sort of portability with your healthcare plan with the Medicare Advantage plan, because you kind of have to stay in your plan service area. So that's one thing to consider with Medicare Advantage, in addition to things like, do you want to continue to see your doctor that you already see who's not in the network? Then you may want to go the original Medicare route. As I mentioned, Medicare Part C includes Parts A and B. It may include Part D. It usually does. And then there's some extra benefits depending on the plan selected. In addition to things like vision, hearing, and dental, there's other sort of wellness preventive benefits that could be part of Medicare Advantage. Some of them have things like a nutrition plan or a fitness membership plan, which are just sort of added perks to get through Medicare Advantage Part C. When do I enroll in Medicare? So the quick quiz that we took earlier, where we talked about, is it automatic or not? Just to reiterate, if you are receiving Social Security, you are automatically enrolled in Medicare. It's always good to make sure that you do receive a letter from the Social Security Administration that confirms your enrollment, that says, that you are going to be automatically enrolled in Medicare. It's always good to call and follow up, but in general, no further action is really needed once you get that confirmation. If you are not collecting Social Security benefits yet, you can enroll during what we call your initial enrollment period. The initial enrollment period is a 7-month window, and it can get kind of confusing. So you can actually enroll in Medicare the 3 months before you turn age 65, which actually is very beneficial, because by enrolling sort of in this earlier portion of your initial enrollment period, you avoid future gaps in coverage. So your 7-month window includes the 3 months before the month of your 65th birthday, the month of your 61st birthday, and then the 3 months after your 65th birthday. So if you were born in June, you have, let's say, March, April, May to enroll, and then you have the month of June as well, and then you'll have July, August, September. So that's your 7-month window to enroll in Medicare for the very first time. Late enrollment, if you miss that window when you could have done it and you don't have creditable coverage, let's say that's like through an employer. If you don't have coverage and you don't enroll in Medicare during the time that you have your initial enrollment period, you can incur penalties for Part B and Part D. And sometimes those penalties will stay with you throughout the whole course of your Medicare coverage. And so initial enrollment timing is really critical. There are special enrollment periods, and this is what I referenced. Let's say if you do continue to work and you have employer-based coverage, you will not incur a penalty for not enrolling in Medicare. You're able to sort of delay your Medicare enrollment if you choose. We encourage you to work with your Human Resources and Benefits Department to determine the timing of that and when you need to enroll, but there are special enrollment periods for that sort of when you do decide to retire or end the employer coverage or switch over. There is a time that's not necessarily the 7-month window. That's another time period for when you can transition from that employer-based sponsor coverage to Medicare. Quickly, some resources. I referenced Medicare.gov. Their website is Medicare.gov. They also have a phone number, which is actually 1-800-Medicare. But here's the digits here, 800-633-4227 if you need help. And Medicare.gov has tools like the plan finder that I mentioned. And those are really good tools to help you make comparisons between plans, and you can kind of filter and choose what kind of plans you're looking for. So Medicare.gov is a really great resource. You also want to look at your state health insurance assistance program. That's available at the shiptacenter.org, and the number is 1-877-839-2675. Sometimes you may just want to talk to someone to ask your questions about Medicare as you're either actively enrolling, or if you already are a beneficiary, how to use it, what it covers. The SHIPs provide, the SHIP TA Center, the state health insurance assistance programs do provide that credible, trustworthy, unbiased counseling. It's sort of this individualized one-on-one counseling that they offer for free. And it's a benefit that you get through the states, through your own state, and you'll have your own sort of website and phone number to call or that they'll direct you to in your state. And it's a great way to get questions about your own specific individual situation. As I mentioned, everyone's situations are unique, and what works for some people might not work for you. And so it's a lot of decisions to kind of consider, a lot of factors. And if you just want some additional assistance, you can get that through Medicare.gov, the state health insurance program, and of course, AARP is here to help as well. In conclusion, we covered some basics, which, as I mentioned, it does cover a lot of the different parts of Medicare and general enrollment information, which is really critical to know. We talked about your Medicare choices, your sort of 2 different pathways on how you can obtain your Medicare coverage. I will note that you are able to change your mind later. So let's say after 1 year of Medicare Advantage, you decide you want to go back. You're able to do those kinds of changes during what they call an open enrollment period. I know later this year we'll have another webinar to talk about that, but I did want to distinguish that the open enrollment period is for people who are already enrolled in Medicare, and that's when you make changes. If you want to switch plans, if you want to switch your Part D plan, if you want to go from original Medicare to Medicare Advantage or vice versa, an open enrollment period, which happens in the fall in October 15th through December 7th every year. That's different from those who are enrolling in Medicare for the very first time. When you're enrolling in Medicare for the first time, that's when it's an initial enrollment period, and you have that sort of 7-month window, or you have this special window because you switched from an employer coverage. So that's in general some information about choices. And then we talked about some resources and tools that are helpful to you. And I know our next speaker, Lance, will provide a lot more information that will be helpful to you all. Lance?
Thank you, Tricia. That was excellent. I really especially appreciated your analogy with the restaurant week and explaining the difference between Medicare, standard Medicare, and Medicare Advantage plans. It's a question we get all the time at the helpline, so thank you. It's my pleasure now to welcome our second guest speaker, Lance Wilson. Lance is a neuroscience medical social worker who works with individuals diagnosed with movement disorders such as Parkinson's disease. He works at the Jefferson Health Comprehensive Parkinson's Disease and Movement Disorders Center in Philadelphia, a Parkinson's Foundation Center of Excellence. Lance has worked in the medical and mental health field for over 5 years, providing education to people with Parkinson's disease and their families, and helping them navigate these complex healthcare systems. Welcome, Lance.
Thank you, Adolfo. Hi, everybody. Thank you for joining us today. Again, my name is Lance Wilson, and I am with Jefferson Health, and I am tasked with kind of taking some of the information that Tricia provided you all a little bit earlier and kind of nailing it down specifically how this impacts people who are affected by Parkinson's disease. So the one thing I do want to touch base on that Tricia went over in regards to Medicare coverage is she was talking primarily about the people who are hitting that age of 65. So I do want to differentiate that for our individuals who have early onset or who might not be at that 65-year part of their life. That there are exceptions to getting on Medicare prior to that, falling under special eligibility requirements. So as Tricia mentioned, people who are on Social Security disability, those people, if you are on Social Security disability for 2 years, or Medicare will say 24 months, you then become eligible for applying for Medicare coverage. So I just wanted to touch base on that because that is something that affects a lot of our early onset individuals who might not be at the 65-year part of their life. So one thing that I want to touch on before we kind of dive into everything is I want to take a quick look at the healthcare continuum because at any point, every single one of us are in one of these places throughout our life. So starting with the acute hospital, of course, which, go to the emergency room and you have to be admitted and you have to be treated. That's the acute hospital. We have LTACs or long-term acute care hospitals, which are for people who still need an acute level of care, but it's not necessary in the emergent hospital. Of course, acute inpatient rehab hospitals, such as primarily you would be looking at rehabs that are for people with amputations, strokes, traumatic brain injuries, or in some type of traumatic incidents that put them in the hospital and they need an intense level of rehab to recover. A lot of the one that people are typically most familiar with are subacute or skilled nursing facilities, which are facilities that you pretty much are, it's less than the acute rehab. Acute rehab is 3 to 5 hours of rehab a day, while a subacute is 1 to 3. So typically after a complicated hospital course, or if you're evaluated by physical therapy in the hospital, sometimes you will be asked if you want to have a short stay in a skilled nursing facility or a subacute nursing facility. Then we have the nursing home, which most people understand as long-term care, assisted living, home health, outpatient care, and independent living. So the one thing I do want to point out before I kind of poll you guys is the Medicare does not cover assisted living or long-term care, as Tricia mentioned. There is something called the Medicaid waiver that is state dependent that you can apply for that can cover in-home assistance as well as long-term care in a facility, but Medicare itself does not do that. It will pay for short-term rehab and the other things that it considers medically necessary. Now, just so I have an idea of what you guys are most interested in, because I'll spend a little more time with that, what do you guys want to hear about? Because I'm going to be hitting all of these topics, but I want to make sure that I spend a little more time on the things that are most important to you. So we're going to be looking at specialist care, medications, medical equipment, home health services, and mental health care. So I'm curious to see what you guys have to say about those and which ones you would like me to go over. Okay, so it looks like the majority of you said all of the above. So good, makes me feel like I know what I'm talking about sometimes. And it looks like, so 30% all of the above, 29%. It looks like most people are interested in home health services. We have 14 talking about their specialist care, 13% about medication, 7% about medical equipment, and 6% about mental health care. So it's kind of spread along the continuum. So that's great. So we'll dive right in. Okay, so I'm going to be trying to do a lot of linkage back to Tricia's presentation, hopefully to make everything succinct and make sense. So for most people who have Parkinson's disease, not all, they typically are seeing a movement disorder specialist, which is a subset of neurology. So that Medicare Part B would be the thing that would be taking care of those outpatient neurology appointments. Now, of course, we also mentioned Part C, which, of course, that is kind of, you kind of are under the umbrella of that local insurance company. So, of course, as long as they are in network with your providers in network with that Part C plan, that should not be an issue. But from Part B, that would be what is primarily covering your specialist stays or visits, I should say. Now, I do want to talk about medications because this comes up a lot in my daily life as a social worker that specializes in Parkinson's. So I want to differentiate Part C and Part D, which Tricia also already did. But of course, taking a look at that bundle that Part C is, because it kind of incorporates all your care as opposed to the fee for service. Now, some of the terms that we typically will hear in regards to someone getting their medication covered, it typically leans back towards what is on the formulary. And I'm glad that Tricia had mentioned those who are enrolled in Medicare. If you are interested in updating or finding a new plan, then you should absolutely go to the Medicare.gov website. It is really great, and I use it as a resource for my patients who are looking to figure out what is the best plan for them, and also taking into account that formularies, which is that approved list of drugs that your insurance will cover for your Part D plan, as well as those Part C plans, they can change. They are subject to change. They can change every year. So one medication that might have been covered can easily not be covered the next year. And I see a lot of confusion and people who are upset about, I've been on this drug for 5 years and now all of a sudden I can't get it covered. And that's likely because the insurance company changed the formulary or the tier that the medication falls on. So some terms you might hear would likely be something called a formulary exclusion. So a formulary exclusion is when your plan just is not covering at all. There is nothing that your physician can say. There's nothing that can be done. That drug is just not covered. Then you have a formulary exception, which typically means that it's a high tier drug on the plan, or it's a drug that the insurance company would not typically cover without medical rationale to cover it. So typically that looks like similar to the last thing on that list, which is a prior authorization, which is pretty much the physician's office making a case to your insurance company as to why you need to be on said drug. And sometimes there are stipulations as to what drugs you might need to try and fail. And fail means it didn't have any effect or it had terrible side effects. So there are sometimes you kind of have to go with the motions in order to get the things covered as well. And then also there's something called a tier reduction. So for every drug, especially the specialty drugs, your drug plan will tier it. So of course, the generic things that have been out for a while, like carbidopa, levodopa, that will be a lower tier. So that's something that insurance plans have no problem covering. Now, once you start getting into name brand drugs that are not generic, that is typically where they're at a higher tier that you likely want to try and, by lowering the tier, you lower the cost and increase how much the insurance is going to pay for it. So I'm sure I'll have some more questions about that, but keep moving right along. Another thing that Tricia talked about was durable medical equipment. And this comes up a lot because I order a lot of it. So we have the rolling walker, commodes, rollators, which is the walker with the seat. I'm starting to come and find out that a lot of people don't differentiate a rolling walker and a rollator, but they are different. Of course, a manual and transport chair. The difference between those is one, of course, has the big wheels that someone can self-propel, as opposed to a transport chair, which is all small wheels and it's meant to be pushed. Motorized wheelchairs and scooters, hospital beds, Hoyer lifts, of course, tube feedings and suction machines, all things that I have ordered throughout my journey as a PD-specific social worker. Not saying that all people need these things, but they are available. The things that I do want to mention and point out are shower chairs. Shower chairs are not typically covered by insurance. One of the kind of tricks that I tell my patients is that if we can qualify you for a commode, if it is medically necessary for a commode, and for those who don't know what a commode is, that is the bedside toilet. That's the official name for it. So there's something called a 3-in-1 commode. And what a 3-in-1 commode is that it can act as a bedside toilet for you, especially for those individuals who can't always make it to the bathroom. It's really helpful at night. Because sometimes it's riskier for one of our people with Parkinson's to try and make it to the bathroom in the middle of the night, as opposed to just using a commode. You also have the 3-to-1. I mean, you also have the shower chair, which of course can be used in the shower. And then there is also the other use of it as a toilet seat raiser. So for the individuals who might have that really low toilet that, it's a fall risk and for that you could possibly injure yourself. We want to make sure that you have something that can help you up after you are finished using the bathroom. So there is a kind of caveat to get a shower chair covered, but typically by itself as an individual, it's nothing. It's not covered, and it's something you have to pay out of pocket for. And if you can't find one, you can easily find one on the internet, or you can go to your local pharmacy because they do have them in stock. Now, a piece of equipment that I became more familiar with as I started specializing in Parkinson's is a lift chair. So a lift chair is that mechanism that you usually have under like a reclining chair that can kind of spring you up and help you catch yourself. So more and more recently, people have been requesting that I order those. And the thing that I have to tell people about those is that the only thing that Medicare covers in regards to the lift chair is the actual mechanism. So some people will try and get the mechanism and install it or have it installed in a piece of equipment they already own, or they will go ahead and just purchase a seat outright. And then what happens is you submit a claim to Medicare, or if it's from a medical equipment store, they can help you submit the claim to Medicare to get some of that reimbursed. The other thing I want to touch base on is the 5-year rule. So Medicare has this policy that if you have a piece of equipment that they've paid for, and it is something that is that you let's say you just want another one. So let's say you have a rolling walker and now you want a rollator. The rolling walker is not damaged beyond repair, and you got it recently, then what is going to take place is that you will likely be paying out of pocket for that equipment. The 5-year rule is kind of a rule of thumb to know when you are able to purchase or when Medicare is willing to purchase a new thing. But you can always work with a representative at a medical equipment store to help walk you through this if that is something that you're trying to navigate as well. Or you can call your local, friendly local neighborhood social worker. And yep, we talked about reimbursement, so we'll move right along. So this is the part that usually takes up a lot of my time explaining because it is very confusing. But home health services, it is something that people, especially who want to remain in their homes, will want to discuss because the facility is likely not something that most people want to follow up with. So I just want to differentiate the different types of home health services. So you have, of course, skilled care, which is nursing, physical therapy, occupational therapy, and speech therapy. All of those services can be billed under Medicare. Now, the things that are not typically covered, there are caveats to this, but the things that are not considered skilled needs within the home care realm are home health aides and medical social workers. I do want to differentiate the language because I do get asked oftentimes, I need a nurse to come and help me out. And I was like, okay, well, what do you need the nurse for? Do you have wounds? Do you have, are you on IV antibiotics? Do you need help dealing with medication? Like, what is the skilled need that the nurse needs to come out for? And then likely time, I need help with, things like cooking, cleaning, bathing, those activities of daily living or ADLs. As you might hear it referred to, is not something that a nurse would come out to help you with. That would fall under the range of a home health aide. So the home health aides and the medical social workers, if it's a home care agency, then they can come out while one of the other skilled services is actually in the home, but they typically do not stand alone for a home care referral. The other thing I want to touch base on is in-home services does not necessarily mean home health. So to take it back to kind of what we discussed previously in regards to fee-for-service Medicare. So some people call it red, white, and blue, original Medicare, whatever your name is for it, the one that's broken up into A, B, and D. So typically in-home services can be categorized or billed under Medicare under either Part A or Part B. Now, I know that there's been a lot of confusion in regards to the Medicare cap on therapy, because of course we know that our people with Parkinson's need to maintain movement, they need to continue to exercise, they need to do their rehab and all of those things to keep them moving, to keep them healthy, because we know that exercise is important for individuals with Parkinson's disease. So the reason that I want to touch base on the Medicare cap is the first thing is that the therapy cap applies primarily to the original Medicare. So a lot of times people will say the therapy cap is gone, but I can't get any therapy. So there are still guidelines that you need to meet in order to continue therapy. It's almost similar to providing medical necessity to Medicare as to why you need to continue therapy. You might hear the term plateau or new baseline. And once an individual meets their baseline or they start to plateau in regards to that rehab care, their case is usually closed out. Now, the reason that the cap is important is because the individuals who are using a home health agency, and the way to differentiate an in-home service versus a home health agency. And the reason I want to make that distinction is that there are programs that will bill Part B through your Medicare, and that can come into your home, but they're not a nursing agency, they're a rehab agency. So that is not the same thing as a home health agency, which has all of these disciplines that I had mentioned previously. Now, the reason that's important is because under the way that home health is billed for skilled therapy under a home health agency, that's billed under the Part A. So similar to it's the same one that would pay for your hospitalizations. So the reason that the therapy cap is important is because those home health agencies can transition over to Part B while still in your home to continue your therapy. So I hope that alleviates some of those questions that come up primarily around why can't I continue therapy, or what does it mean when I'm being told that my services are being terminated? Because at the end of the day, you still do have to show gains. And there's always something you can always reimburse or file a claim to Medicare to see if they're willing to cover it. But typically, the issue is going to be, do you have gains realistic to obtaining your baseline? And I would be not a very good social worker if I did not touch base on this difficult topic. A lot of people do not like to talk about this, but I think it's important to talk about advanced care planning and what that means and what that looks like for, of course, end of life care. Because one of the worst things that can happen is when you're put in a situation And this is for really everybody. But primarily, we're talking about, of course, individuals with Parkinson's and who have Medicare. So I want to make a distinction between palliative and hospice. Sometimes these words are used interchangeably, but not always correctly. So one of the things to understand about palliative care is that hospice is a type of palliative care, but palliative care does not necessarily mean it's hospice. So palliative care, of course, is looking at making sure that that you're comfortable and quality of life, as well as things like cleaning up the med list, and someone, usually a gerontologist, who is a little more skilled with navigating those who are elderly, as well as if you take a look at hospice, then we're typically talking about end of life care. So with that comes a few different examples of how that is covered and what that could possibly look like. So if you're talking about an inpatient unit, you're typically talking about someone who is imminent. So they are actively dying, and it's a facility that is typically used for making sure that their loved ones have a place for them, as well as offering a safe place for them to transition. Now, the one thing that comes up a lot as a medical social worker is that if someone is unable to be taken care of at home, and hospice or palliative is the option that we're looking at, sometimes people will say, okay, we'll find a long-term care facility and we'll transition our loved one into there. The misconception with that is that if the individual is not already a member or a long-term care individual at that facility, then Medicare will only cover the actual hospice services. They will not cover the room and board for that nursing facility, which goes back to something I think me and Tricia both pointed out, is that Medicare does not pay for long-term care. And if you're looking at a nursing facility or a long-term care facility, that is not a benefit that Medicare covers. And then lastly, and this is the one that most people end up dealing with, is the home with services. So, the one thing I do want to point out about an inpatient unit is that you have to qualify medically for it. It is not something that, unless you're paying for it, if you don't qualify, you likely will not be able to get into an IPU. Back to the home with services, this is what most people are doing. So this is what the palliative home care or the hospice agency is coming in. They will make sure any equipment that is necessary or that is needed, they will handle that. Those hospice agencies typically also will discuss or reiterate your, do not resuscitate or do not intubate in goals of care, and have that conversation, do not hospitalize orders, and then ultimately advance directives and power of attorneys, and kind of helping get all of that guesswork out of the way, because it's really hard to be present with your loved one if there is something imminent happening to them, when you have to try and finagle all of these kind of legal and trying to fix everything while also trying to be present with them. And the reason that I wanted to touch base on mental health primarily is because COVID has done a number on everyone, but especially our individuals with Parkinson's disease. So I've been doing a lot of psychoeducation and providing a lot of information about mental health resources, because it's not something that I feel like a lot of people widely, bought into until they started seeing some of the effects that COVID had for that isolation. So for the individuals who that know this, great. For those, then I hope that this is a new lesson for you. And I want to differentiate psychotherapy or talk therapy versus psychiatry. I think that a lot of times people will recommend psychiatry, who is, of course, a physician, but ultimately that is looking more so at the medication side of things. Psychotherapy is typically you're talking to a clinical social worker or a counselor. So the differentiation is that the psychotherapy is more so the safe space for you to discuss some of the things that might be bothering you. And then a lot of times psychotherapists can refer you to a psychiatrist if you are unsure of where to go. And an answer or a question I get a lot is, how can I identify a provider that primarily specializes in Parkinson's? And while some of those individuals do exist, this is the list of some of the other things that I tell individuals to take a look at in regards to trying to identify a provider that is appropriate for them. So someone who is really good with handling anxiety, depression, grief, and chronic illness are the individuals that would be ideal if you can't find someone who specializes in Parkinson's disease. But also in this realm, protect yourself, because I often hear I had to teach my therapist about, about the disease state and what it does and what it affects. And I will say, though a therapist may not be all familiar with all the avenues that Parkinson's can take, it is sometimes counterproductive if you have to explain your disease to someone who's supposed to be helping you prevent or address your own mental health. And that's all I got. So thank you, guys. I hope that you got something from our presentation.
Thank you, Lance. Excellent presentation. So we have lots and lots of questions. So we have decided to go over an extra 5 minutes so we can try to get to as many questions as possible. And also, if we obviously are not going to get to all of them, but you can always contact the Parkinson's Foundation helpline at 1-800-473-4636, 1-800-4PD-INFO. For help with your questions, as well as the AARP caregiving helpline. So right off the bat, we'll start with one of our first questions. And I'd like to direct this to Tricia. Tricia, if you could explain once again, we've got several questions regarding the deductible period of the 60 days for Medicare. Does that mean that if I am hospitalized and then I'm out of the hospital, and then 90 days after that, I have a second hospitalization, the clock starts ticking again? Am I liable for a new deductible?
I believe so. Lance, you might know more than me, but I think it's individual hospital stays. So it's a 60-day consecutive days in the hospital, and then an additional one would start again.
So my understanding is actually so I probably talk more about the opposite. About staying out of the hospital for 60 days, because I'm talking about the renewal or the restart of the Medicare days. So Tricia, you have that. I'll be learning from you. So.
Okay, so that sounds like that's one that we may need to get back to our viewers on, and requires a little more investigation. This other one might be a little bit easier. If someone has purchased a durable medical equipment or any object that is covered, say like a transport wheelchair, but they purchased it privately. If they hang on to the receipts, if they have a prescription, can they submit after the fact for a reimbursement?
Yes. I believe so. Mm-hmm.
Yep. So for individuals who will get equipment that they did not include their insurance in, as long as it is something that Medicare approves, they can submit a formal claim to Medicare for reimbursement.
And as long as that specific type of equipment is on the approved list and covered.
Next question. If someone is not at 65 yet and they're receiving SSDI, can they move to Medicare 24 months after they become eligible for the SSDI payments? Is that the trigger or the caveat? And is this something they need to initiate on their own once 24 months has passed?
So yes. So after the 24 months of being on Social Security disability, you are eligible for Medicare. And like Tricia had mentioned, for those individuals who are already receiving benefits, you will be enrolled or kind of bumped over to Medicare after that period.
One of our other participants is asking about TRICARE, which seems to be a wraparound type coverage for our military. And as many will know, a lot of our military do have Parkinson's disease. How does that affect your ability with, is that considered one of the sort of Medicaid or Medicare Advantage Part Cs, or does that impede, if you take advantage of that, accessing any other benefits?
In general, I think Medicare and TRICARE coordinate similar to how a primary and a secondary insurance works together. I believe that once you're eligible for Medicare, and if you have TRICARE, that Medicare becomes the primary payer and that TRICARE becomes secondary and can kind of pay for the things that the primary Medicare will cover.
Excellent, thank you. And Lance or Tricia, getting back to the topic of mental health, which was your last slide there, Lance, is there a distinction in coverage? If you could elaborate on that a little bit again regarding whether it's a psychiatrist, which obviously would be a medical doctor, versus a psychotherapist who might fall under not the medical category?
Absolutely. I apologize for not linking that back. So both of those services typically fall under the Medicare Part B portion of your insurance, or if you have a Part C plan or Advantage plan, as long as that person is in your network, you likely will just have a copay that you will have to handle. But a lot of people, if they don't take Medicare at all, then you'll likely be paying out of pocket for their services.
And then once again, home care, we have several questions regarding
I knew it.
And I can say that's one of the most popular or more common questions we hear on our helpline. Where does, if at all, does respite fall under this? Many of our families that have loved ones with Parkinson's don't necessarily need full-time care, but sometimes they just need a few hours, or they need something, a bank of time. Are any of those respite type services available under any of the Medicare related programs?
So typically respite care, and Tricia, please, if you know something other, please let me know. Typically it's something that's paid for out of pocket unless the individual qualifies for that state waiver that I was mentioning through Medicaid, to get someone to come out to the house or to cover some of those, that time in a facility. Typically that's something that is paid for out of pocket.
I believe that's true, and that if there is coverage, that it would only come out through the hospice care benefit.
Okay, I apologize for a second here. We have so many questions. We're trying to pull out the ones that are going to get applied to most individuals. So here's another interesting one regarding therapies, and that is, if someone has hit their maximum or for eligibility for therapy services, and now they have, say, an accident, they break a leg or something else occurs that then warrants additional therapy, will Medicare cover that, or is it counted against the fact that they've already fulfilled perhaps their maximum for the year?
So it depends on if they're talking about inpatient or outpatient. So if they're talking about inpatient, typically Medicare gives you 100 days. And then once you hit your 100 days, you need to remain out of a facility for 60 days. And then we'd be looking at home care. But if they're talking about home care or outpatient, then typically what we're looking at is you have had a change in medical or a change in status. So you can reapply for services, and they will understand that your baseline is nowhere near where you once were when they discharged you previously. So a change in status is a actual rationale to get additional therapy.
Be considered a qualifying event.
Exactly.
That would trigger. And so we also talked about, it was mentioned about the, in some instances, waiver programs. How are those accessed, and are there, it's my understanding, I think that this is just from some personal knowledge, that some states may have their own waiver programs. Is that true?
Correct. You're on money, Adolfo. So every state has their own waiver program because it is based under the state Medicaid. waiver. So the first place I typically refer people to is to find their county office on aging. So here in Philadelphia, we have PCA, or the Philadelphia Corporation for Aging. But for every county, there is a aging and disability resource that would actually be able to initiate the assessment that's needed to get that in-home covered care. Of course, looking at assets, and then they would come out and do an actual assessment of the individual and their living environment to dictate what type of services they would help.
Okay, so we have time for two more quick questions. And one is there any coverage for, under any of these programs, for things such as fitness type programs? Whereas we know the therapy, there are limits, but Parkinson's particularly, there's all of these exercise programs such as the boxing programs and various different therapeutic type exercise classes or silver sneakers and things of this nature. Is any of that covered under, or possibly covered under, any of the programs?
So my understanding is that they're not covered because it's seen as an addition, an exercise program, because you're having the physical therapist or whichever type of therapist come in to teach you techniques that have to be done outside of when they're actually treating you. So things like boxing and cycling are not typically covered if it's in an additional program. But I always tell people, you never know. You can always submit it to Medicare and see.
And I think if it's for the purposes of the, therapeutic, I think that's different from if it's a wellness preventive benefit, which sometimes can be covered through a Medicare Advantage or Part C plan. That's one of those additional benefits that's not going to be covered through original Medicare. But if you happen to find a Part C Medicare Advantage plan that does cover things like gym memberships or certain, one-on-one kind of sessions, that kind of thing, that's more for the preventive wellness side of things, and that might be covered through Medicare Advantage, but not all.
And our final question, which I think would be a good recap based on several of the other questions that have come in, and it relates to those differences between Medicare versus Medicare Advantage. Several people have submitted the question saying, if I have Parkinson's, what's the best plan to get? And I know you mentioned, Tricia, specifically, it depends and your situation, but maybe if we could wrap up by having you give just kind of like, what is that quick checklist again of things that are questions people should ask themselves when they're evaluating which path to take?
It does absolutely depend. I think it depends on how you generally like to obtain your health coverage. If you're someone who's always wanted more freedom in terms of networks and not requiring referrals, then I would go through a PPO type way of getting things, which is going to be through original Medicare, where it's more a la carte, and generally a large number percentage of providers will accept original Medicare. Sometimes that comes at a cost of paying more, out of pocket, or more through, your monthly premium. And then if you're someone who wants more convenience of the one-stop shop and you're in an area that has Medicare Advantage, that's another factor to consider. Sometimes rural areas aren't going to have service providers in the network, or they may not even offer a plan in your area. So those are things to consider: is where you live, how you want to obtain your coverage. Is it convenient for you to have it all in one stop, or is it more convenient for you to have flexibility and freedom in choosing your providers? Then the other aspect that I mentioned is thinking about sort of your traveling. Not sure if you are someone who does want to travel, that portability aspect. Medicare Advantage is limited. You have to stay within your plan service provider's network, and you may not get that coverage if you go somewhere else. So it truly does depend. And my advice is, don't just look at costs. You really have to do your research, and it is a lot of work, but know that you're not locked in, and it's not the end of the day. It's not the end of the world if you go with the plan and you decide that you don't like it. There are enrollment periods, like in open enrollment times, where you can make switches and changes to your coverage.
Thank you so much, Lance and Tricia, for all the information you've shared with us today and for the time. And I want to thank everyone for viewing and participating in today's webinar. But before we wrap up, please, we ask you do not go away. There is a lot to cover in Medicare. So we have a part 2 to this series that will be taking place in the fall. If you have registered for this webinar, or which those of you that are present here, there's nothing else you need to do. You will be receiving a reminder email for the next one, which will be taking place October 21st. We also want to remind you about the additional resources that we have available to you, both at the Parkinson's Foundation as resources. You can see everything from our national helpline to our hospitalization kit, publications, reach out, and we will try to answer your questions and supply you with the information, make the best choices possible. And also our partner in this webinar series, AARP. Do not forget about their AARP.org Medicare website, which has a ton of information and many of these questions answered for you. And last but not least, we ask you to stay one more minute as we deploy our survey as soon as we close the webinar. An online survey is going to pop up on your screen. Your feedback is very important to us as we help us to improve in future webinars for Parkinson's care in the community, and we welcome suggestions for future topics. Once again, this webinar has been recorded and will be available for on-demand viewing within 48 hours. You'll be notified via an email as soon as it's up for viewing. Thank you once again for being with us today. We look forward to connecting with you again in the fall. Take care, everyone. Thank you.